This is Roberto Zaldivar from Mendoza, Argentina, famous for Malbec, also famous for cataract and refractive surgery, thanks to Dr. Zaldivar. Today we're going to talk a little bit about some of his experience in bringing new technologies to the world and to South America, and some of his experience developing instruments and his views going forward. All right. Okay, so Dr. Zaldivar, I understand that you were one of the first developers of the ICL lens, or one of the first surgeons to install it.
Yes, was true. We have a very big experience here, very long, and we had the opportunity to travel with the first group of people from START to Russia in '89 and '91. At that time, they were interested in the pattern of field about posterior phakic wall, and they asked me to go with them went with them to try to see the new technology. They bought the technology, and in 1993, it was the first group of people who implanted in the Western Hemisphere after developed the ICL that we call ICL. At that time was not ICL. The first patient that was implanted between the half at the end of 1993. And our first ICL was implanted the 22nd of September of 1993.
Okay. So what kind of challenges did you have initially with implanting the lens?
We have almost no reference to do it. The only reference that we have is a small experience to see the original field of lens. That we don't have adequate instrument. We don't have injector that we put it flat. We don't know nothing to do, just put it under the iris, but we don't know how to do it. And we had to develop all the things. At that time, it's just for the scratch. Even the same year, at the end of the year, we used a tip that was used for a silicone lens for STAR to put the first foldable ICL. That the first foldable ICL, we put it at the end of '93 with the injector that was developed for the normal silicone lens for STAR.
Was there any issue with the amount of space available between the lens and the iris, that you didn't want to contact the lens and so on? What kind of...
At that time, there was a very big lack of knowledge. We don't know if we need a space between the crystalline lens and the lens. We didn't know. We didn't know. This was learning with the time, but nobody knows it's necessary or not. We don't have OCT, that we don't know where the lens is. Ultrasound was very bad, that do not take any information. And a shine flow camera that appeared a couple of years after the shine flow was the first instrument that we can get some information about the position of the lens. At the beginning was empirically, and the only good information that we have is the information that we got from Russia.
Right. So they had been experimenting with it.
They have experience since 1986.
Okay.
That they have some years, but at that time Russia was not like today, and it was very difficult to pick up some information because there was no information even. That we had to learn as we can.
Right. Okay. So as you as the imaging became available, I assume that helped you select patients and do.
Exactly. It's the first thing important that we learned was the vault. The vault was a space that was between the crystalline lens and the cornea, and the endothelium. And this was described by a doctor who's Michael Dietz, who was at that time the coordinator of the study, and he was originally from Kansas. And he described this space as a ball like in 1994, something like this. And they say maybe it is important, but we had to see if the mold is important. And this was described in 1994.
So was the lens shaped? Was it flatter initially, or
Originally it was like a little bit different than now, more like the original Fyodorov lens. And the biggest trouble that the trouble that we have at that time was the movement of the lens. It was not stabilized in
Right.
the eye. That they move, they rotate, they go down, and decentration was an issue.
so then it had to be made bigger, or you had like a
Yeah, because we
flexible
have
haptic
we have
on it?
only one size,
Yeah.
and it's really small. It was
Yeah.
11 and a half. Imagine that now the standard is 13.2.
Right.
At that time we have only one size and it's 11 and a half. That was normal, that the lens was.
Okay.
Yeah.
So what about the instruments that you needed? What was available, and what did you need to develop in order to effectively place
Of course,
the
all
lens?
the instrument that we used at that time was coming from ASICO, from Cataract.
Right.
And we started to develop instrument dedicated to the ICL. And we dedicated spatulas to put it under the iris. We also, at that time, we designed like a diamond, one diamond that I think is very, they used for many years and was very broad use, is the SAP, CAP, that we designed because it's a very sharp diamond that they allow to do very small incision and paracentesis, and it was very useful for the lens from the ICL. Also, we knew tips for injectors because we need a new injector that is dedicated for the ICL because the other injectors are not designed for this, and many times we broke. The other thing that is important, I designed in the injector a metal cell sponge that is still now. I designed in 1994 and still is now in the injector. It's a metal cell sponge because when you push this material that is not like the other IOLs, they have more water content.
Right.
It's very easy to break. Then we designed the metal cell sponge in the tip of the push, and it was an incredible solution from IOL broken, because at the beginning the tip was metal, and when we pushed many times we broke the lens.
Okay. So you came up with what's the tip made of now?
Metal cell is the same.
It's the same.
The same. Metal cell is a sponge. It's a sponge. It's like a
methyl
white.
cellulose. Right.
Yeah, it's
right.
like a sponge, like a white.
Right.
Yeah.
Right. Yeah.
That
I
is rotated.
understand.
Yeah.
Right. Okay. Yes. Methyl cellulose. Okay. So what was different in the shape or the weight? When you put when you inject the ICL, you're not injecting it into the bag. You're injecting it under the iris, or do you inject it into the anterior chamber?
The first group ICL we injected flat, even without fold. That we put it like flat over the iris and then down. And after December of 1993, we started to fold it, put it with the injector, and they open inside the eye. And then we have to decide what is the best technique to put it under the iris. That is not easy at that time, because sometimes the patient is not very well dilated, and put this material under the iris was not easy. That the first thing is how we can put under the iris without traumatize the iris and the crystalline lens. And we start to develop some instrument like spatulas to do this.
So the spatula, then you use it to lift the iris up and slide it
No,
under,
what's like
or
this is more like contract the ICL, like retract the ICL and put it under and retract with the other side. And
so basically it's going in like
yes,
this,
like you cover and put it like
and
this.
so it's not touching the crystalline lens.
Exactly.
It's not touching the endothelium either on the outside.
Also, other thing that is choose what is the right viscoelastic, because all the people have experience with viscoelastic in phaco. It's totally different, because the viscoelastic in phaco, it doesn't matter what we do, because then we take out the crystalline lens. But then we learn that some viscoelastic affect the crystalline lens, and in this case we had to leave the crystalline lens. That some viscoelastic are more more safe than other
Right.
in relation with the crystalline lens. And this is something we had to learn.
Okay, so do you inject visco underneath the lens to protect?
Exactly, the crystalline lens,
Yeah.
and we need a special viscoelastic that do not affect the crystalline lens.
Right, okay, because you're going to leave it in there.
You're gonna leave it or clean it, but the crystalline lens is going to be there.
Right.
No like FECO
Well, okay.
that you're going to
So
take it out.
Either when you,
Yeah.
even when you take it
Yeah.
out, it affects
Yeah.
it. Right, I see.
Yeah.
Okay, so you wouldn't want to leave it in there because of the...
No, nobody leave it, but
Yeah,
the anterior experience is if you put a viscoelastic and they feel the place.
Right,
It doesn't matter that they produce something in the crystalline lens because
right.
you're going to take
Because
it.
you're taking it out.
But this
right.
one, if you put a viscoelastic, they, for example, produce cataract,
Yeah.
then when you leave it, you're going
Right.
to have a cataract because the viscoelastic.
So is it what type of a...
Yeah, we find that some one are more complicated than the other one,
Yeah.
but even the most basic viscoelastic in my hand, like some kind of methyl cellulose, in my hand are the better viscoelastic for the crystalline lens.
Okay, I see. Okay. So when you develop these instruments, do you work with ASICO on some of these?
I work with a lot of companies, but ASICO was one of the first, and we developed many instruments. I don't remember the number, but probably about 40 or something. Because we started doing instruments like diamond for incision, spatulas, instruments to retract the ICL, to pick up the ICL, retract the ICL,
To take it out.
to take it, pick it and fold it in the injector, put it inside the injector. There are instruments for alignment, for astigmative, for control astigmative, to do relaxing incision at the same time,
Right.
centration. We developed really a big number of instruments during this.
Can you tell me about one maybe that stands out in your mind as being particularly helpful or that solved a real problem for you?
Oh, probably the most important was the diamond, the SAP diamond, CAP. That was the other diamond was designed for FECO, and the problem is are very thick, and when you do the incision, you have a low control of the pressure because it's very big, and sometimes you go very fast when you cut, and you can cut the crystalline lens.
Right.
And in a FECO, it's a small problem. In ICL, it's a big problem.
Right.
That we design something that is sharper and smaller, that you have more control and you can do the incision more safe without touching the crystalline lens.
Okay.
Also, spatulas were very important to try to put the distal part of the lens under the iris. That is not the same that the part that you have more closer, because you need an instrument very long that have the shape of the lens to go in the other side, and an instrument that is short to put it in the place that you are operating.
Right. So you need two then.
Or two, or in the same instrument, two sides.
Two sides.
Yeah.
So that's how you...
Yeah.
Okay. You just flip it over.
Yeah.
Okay. Oh, that's very interesting.
Yeah.
So I guess that's a little more efficient than having two.
Yeah,
or-
I have one with the two sides, of
Yeah,
course.
so that's what you use now. You say you've done a lot of FECO instruments as well.
Yeah. Yeah.
Anything?
Most of the idea coming from the ICL instrument that I use. Instead, I use the FECO diamond that I use. It's an evolution of the original SAP that I designed from ICL.
So that-
the name is SAP 2.
Okay.
And it's something like I use it now in FECO.
And the benefit of that is that it gives you more
The
control.
good thing is a very good control. You can do the incision without viscoelastic inside. And also, because the instrument is very thin, you can do the incision the size that you want. Sometimes you want 2.2, sometimes 2.4, and you have one instrument for all.
Right.
Also, the paracentesis can be done with this instrument. It's very sharp.
With the same
Same
blade.
without viscoelastic previously and all. Yeah.
Okay. All right. You're working with lasers or instruments for working with lasers?
Yes, we do a lot of instruments also for LASIK, spatulas, different centration instrument for LASIK. And we introduced the first excimer laser in Latin America, 91. And very soon, in 93, we had 3 lasers in my clinic. Like, it was very, very unusual because 93 just few clinics have laser, and we have three. We have a Summit, that from US. We have the third NIDIC laser of production, the third. And also we have the Chiron Technolas that was also appeared in the market at that time. That we have three different lasers, and we can compare results and other things and help improving the software at that time.
And you also were developing instruments at that time to improve the surgery?
Yes, because at the beginning it was PRK, and we had to develop instrument for peeling the epithelium, dry, centration, and other things, markers. In 94, 95 appeared LASIK, and then we had to start to develop instrument for flaps and everything.
Right, so you can lift them without tearing them or scratching them,
Yeah.
those kind of things, yeah. So again, you worked with ASICO,
I work
ASICO,
also in many instruments from LASIK.
yeah, LASIK, okay. All right, so are you working now with the femtosecond cataract surgery at all?
I do femtosecond cataract and femtosecond LASIK, because the flap, I have 3 LASIK from femtosecond, and I use femto cataract, but I'm not using it all the time, because it's I like, but I like in some cases only, and I am not using it 100%.
Right.
I know some advantages, but also have seen some disadvantages that I prefer to use when I think it's the best situation.
What kind of a situation would you think it's more appropriate for?
For me, it's very appropriate when the patient have very good dilation, when the patient have intermediate cataract, that is not very hard and not very soft, and it's, especially when it's lens that they have been very well centrated, and we want it to be sure, like a premium lens. And if they get all these conditions, I like to use it. But if the patient is not very well dilated, or the cataract is too hard, or something, for me it's not an advance, it's just another problem. I try to use it when I consider it's the best.
What kind of technique do you use for nuclear disassembly?
In a phaco laser?
Right. Or just
because
when you're doing it
when I
manually?
do a femto phaco, I use a technique that I call hybrid. I use a half with the phaco, with the femto, and a half manually. What I do is I did a capsulorhexis with the femto, and I just cut a cylinder in the nucleus. But then the spare part of the cylinder I do with a pre-chopper, with a pre-chopper very sharp, only in the center. I cut in 4 spaces, only the 4 millimeter of the center of the nucleus, done by a pre-chopper. And then I eat this cylinder, and I'm finished like a cylinder hole in the middle of the crystalline lens, and then aspirate the periphery. And it's a very safe procedure for me, especially for phaco-refractive, because phaco-refractive is a procedure that do not allow you to make complication as a normal phaco, because it had to be a very safe procedure. And this kind of procedure for me, in my hand, is extremely safe, because you always leave cortex and only take the nucleus at the beginning, and then the cortex that is in contact with the capsule, you only aspirate it. You never use ultrasound.
Okay. So the advantage of using the pre-chopper in that situation is you don't have to get as close to the capsule.
And I only cut the center. I leave all the periphery,
Right.
even the deepness, isolated with the cortex.
Right.
But I only cut 4 millimeter of nucleus, that is the most difficult to phaco-emulsify. I cut it, I eat it, and leave then the crystalline like with a hole in the middle. And usually the periphery is very easy to aspirate, no ultrasound.
Without ever
Without
have to
ultrasound.
fracture it or cut it or anything.
Nothing.
So
I
you're
do
just,
not
okay.
cut. It's like a thing that you put it and aspirate.
I see. Okay. What kind of tip do you use? Or you
No, it's a regular, like Kelman kind of tip that we use for the Centurion. This is the figure that most use.
So I understand that you're also developing some software for your, what is this for the?
Yeah, we develop, we at the beginning we helped to develop software for different companies to improve laser and all the thing, but 16 years ago, we did a very big work in developing software for the clinic from electronic and medical record and flow. It was very advanced at that time, and now we are doing, we are working a lot of hours a day to doing software that is going to be finished at the end of the year, and I consider it's going to be really a very revolutionary software to organize a clinic.
Okay, and what does that do to predict patient flow? Or
It's a very sophisticated software for ophthalmology, for instrument, for data collection. It's totally different than the rest. That is more. Most of the software are more aimed to have billing or something. This one is more data collection and flow. They have an incredible amount of technology to try to control flow in the clinics. It's very sophisticated. They use face recognition, and they measure all the time that the people are in any place in the clinic, and then they use artificial intelligence to optimize the circuit inside the clinic.
Right. So then it would take into account how much time you have to spend on a case. Or
exactly. You dilate, no dilate. If you put it, you have so many examinations. If you send to another examination that is not already planned, and all this produce a chaos in a normal clinic that asks that the people becoming late or not.
Right.
We have a very sophisticated system that they're going to take years of learning because it's learning out there. But they take care of all this consideration and try to improve the appointment time in any place.
Right.
Yeah.
So how much do you anticipate that'll increase your throughput or your productivity?
No, it's not only increase the productivity, it's increase the prediction of the time that you have to see the patient, and the patient are extremely more happy.
Right.
Even we analyze the humor of the patient, that is happy, not happy or not.
Right.
And with this predict system, the people are a lot more happy because they know how long it's going to take every step.
Right. So they're not waiting around.
No, they're not waiting, but they know.
They know
They
how
say
long
they
it's
have
gonna
like
take.
schedule,
Oh,
and
I see. Yeah.
they say okay, maybe you stay 2 hours in the clinic, but you are going to do this at this time, this at this time. This.
Right. So when they come in, they know what to expect. Yeah. Okay. Well, that's interesting. That's interesting. And you designed your own clinic.
Yeah. Well, this is part of the flow, and many years ago, because I did it like 94. That we finished the first part of the clinic 94. Then we did another part in 2000. I designed the clinic a little bit different. That I visit many clinics in the world to try to take ideas and design a little bit different. And I mentioned one of the most important part is most of the wall are glass, and inside the operating room also was glass. And this is try to see the flow of all the operating room to see if the efficiency is okay or not. But also it's very funny because we don't have direct view very far, because I think the people bother when they saw many patients in one place. Now we have like small corners all over that in any place looks like there are so many people, and there are many people.
Right. Right. So you can see everything that's going on in the clinic. That helps you move patients through, make sure that your employees are functioning efficiently, and so on. Okay. So can you tell us a little bit about the conditions now in South America and Argentina, what you see for the field of ophthalmology in the future, both for the point of view of your practice, but also just generally for the population, what the needs are, how they're going to be met?
I think ophthalmology in Latin America is very well developed. There is probably more asymmetrical than Europe and US. That means they have very good places, very extremely, and some places that are not very good. There are more asymmetry, but they are very good. Most of the people are very well prepared, have very good instruments. But You know, Latin America is something special because you have to deal with the economical situation that even the people from Europe and United States do not understand, that there are so crises so big that in a country like this one can't afford because they don't know how to do it. We learn with the time what happened with inflation, with all the things. But anyway, I prefer to live in a stable country. But as we have experienced this, they affect us, but we are prepared to do it, and we're still doing very well.
It must be a real challenge to keep a business going through something like that.
Yeah, it's an exercise, and we pass so many crises, and our clinic have a privilege that 97% of the patients that we have are not from Mendoza. I mean, coming from over the country or other countries. That this one allow us to have a more stable clinic situation. Yeah.
Do you have any outreach that you're doing to the local community or any of the outlying areas in the country?
You say like foundation. Or, we have clinic in Buenos Aires. We have two clinics in Buenos Aires and a couple of clinics in different parts. But also we have a foundation that is an institution that we operate free, totally free. All is free for the patient, charity, and they are very active. We have many doctors of the clinic who donate his hour for the foundation. I have different operative in different parts of the country for really extreme poor people.
And how do you work with what kind of procedures you
perform in this place?
Right.
Usually it's diagnostics, and then when we find what kind of pathology they have, many times we bring to the foundation clinic that is close to the institute, and we operate it, and we operate it free.
Do you see a big increase in need coming in the country, or how is the how effectively are there enough ophthalmologists there to?
No, yeah, we have Argentina is the country that have more ophthalmology per people in the world. That means we have enough.
So you have enough. Right?
Yeah.
Yeah. Well, that's great. Is there anything else that you wanted to add, or that we haven't talked about that you would like to?
No, I think it's for youngest people. Innovation is part of our business, and it really helps the improvement that we see all the day here in the commerce.
Okay.
And all the people who wants to do innovation is really incredible. They take a lot of time, but also you have to find very good people, engineers, or people who can convert your innovation in reality. And I have experience with very good people here in ASICO with Ravi. That with the paper, with a couple of drawings in the paper, he transformed in an instrument in a couple of months. That was amazing. That the people who have experience and can do this is a privilege, and I am extremely happy to do this all day.
And that's really made it possible for you to improve the ICL procedure and the other things that you're doing.
It was dramatically improving because there are some problems that the people don't know, and was dramatically improved because instrument, because instrument.
Right.
Yeah.
So it really was critical to advancing
the
technology. It just wouldn't exist without it. It sounds
exactly.
Like. Well, it's very nice talking to you today.
Okay, thank you. Thank you very much.
Thank you.
It was a blessing.
Thank you.